I'm going to talk about soul. Now, you have all heard the lectures about soul so many times. I think you are bored, and I am also bored. So what I will do is, towards when I finish that, I will put up questions which I have, some searching questions. Answer देना पड़ेगा, ये क्यों नहीं हुआ, वो क्यों नहीं हुआ, and then let us see if we can get answers to them. So this is the financial disclosure. Now, already the pioneer trial was already there with the oral semaglutide. It did not reach statistical significance with the 3-point MACE. It was a shorter trial with less number of patients, necessitating a larger trial with larger number of patients. So then the soul. So few things which we have to appreciate here. So there are about, can I have a pointer, please? There are about close to 10,000 patients and about 800 from India. But look at the timeline. It is about 5 years. This is one of the longest CVOTs of any drug, matched perhaps by Declare-TIMI. So 5 years, koi effect ho, koi side effect ho, all will come to the fore. Now, the inclusion criteria was patients with more than 50 years of age. और इसी में मेरा रोना है कि majority of the CVOTs, they consider patients with included patients with age of more than 50 years. Type 2 diabetes, uncontrolled HbA1c 6.5 to 10 with one of the risk factors which is given here. Can I have a pointer, please? Now, in the demography, a few things to be noted. The baseline HbA1c was 8%. Look at the type 2 diabetes duration. It's about 15 years. I'll use the mouse here. It's about 15 years. And the blood pressure was relatively well controlled. So well controlled, but 15 years of diabetes, okay? Now, I have to make a correction to this slide here. Now here if you see, heart failure patients were about a quarter of them. Now the eGFR, if you notice, and I have an objection to this, this is incorrect. We don't consider GFR more than 60 as CKD. CKD is technically defined as eGFR less than 60 and or albuminuria. So in this trial, patients with eGFR of more than 60 was 70%. This has got an importance. I will tell you when I visit the CKD data of the soul. So more than 70% of patients had eGFR more than 60. You see the mean eGFR is 73. Okay, so I'll tell you the importance of that later on. So these are the concomitant medications. Importantly, quarter of them were all SGLT2s. At the end of the trial, 50% were on SGLT2s. See, 50% of the patients were on insulin. And at the end of the trial, the hypoglycemia rate was comparable. So that's important because they are having a cardiac issue. They are having cardiovascular disease. We do not want hypoglycemia to occur. And 50% of them were on insulin. Still, the hypoglycemia rate was comparable between the semaglutide and the placebo arm. So the primary outcomes. So the 3-point MACE was reduced statistically significant. Look at the p-values, 0.0028. And the separation was quite early, less than 6 months. It began to separate and it stayed separate. Many of the curves, you might find it comes close, then goes up, then comes close. But here, there is a continuous widening of the curve. That gives us a lot of reassurance that the effect is quick and persistent. Now, the biggest driver was non-fatal MI. So that's 26%. What about the stroke? Why is the stroke not significant? हम लोग तो यही पढ़ते आए हैं कि GLP-1 receptor agonist stroke को कम करता है. इसमें क्यों नहीं आया? I will answer that later. So non-fatal MI is 26% reduction. Mind you, if you look at all the trials, only one other trial reduced non-fatal MI, which is the Harmony albuglutide, which is not available. So amongst the available GLP-1 receptor agonists, this we can tell the patients. I tell my patients कि आपके heart attack को मैं 26% कम कर सकता हूँ. And that's a very, very powerful message we can give to the patients. Now the benefit, you can see the subgroup analysis, and here there was a reduction of 27% in HbA1c more than 8, and particularly in Asian patients. But this was not powered to do a subgroup analysis. I'm reading it because it's there in the slide, but that's what the data, what they have shown. So overall, if you look at all the GLP-1 receptor agonists, SOUL reinforces the CV benefits. Now the secondary outcomes, and here lies the interesting bit. CV death was not statistically significant, reduced by 7%, but not statistically significant. And this, I think, is very important. The major adverse limb events. What is that? Hospitalization for acute or chronic limb ischemia. None of the CV outcomes, none of them have addressed this. This is such an important problem we have, not only in India, everywhere. And none of the CVOTs address this. Can you tell me one CVOT which had this? It was proactive trial with the pioglitazone, and there was an increase in the amputation there. So none of the CVOTs have addressed this. So I'm so glad that they have just done this as a confirmatory secondary outcome. Now, surprisingly, funnily, you can see at 2 years, the curve is crossing each other. In fact, if you do it just a few months before 2 years, it is worse. And then suddenly at 2 years, the line separates. So we asked this to the trial, which we don't know. But that's the advantage of having a longer trial. If we had stopped the trial here, then the answer would be different. But because it was a longer trial, then maybe the atherogenic process in the peripheral vascular disease is, I don't know, it is different. But at the end, there was at least a 30% reduction in the major adverse limb events. So I can tell my patients as well, not only it will cause less heart attack, but it will also protect your limbs. Now the renal outcomes. Now, if you see the 5-point major kidney outcomes. Now this, I was a little bit disappointed, to be honest. You can see here, there is a 9% reduction in the 5-point kidney disease outcome. Now note here, in the kidney disease outcome, there is kidney death, persistent 50% reduction. There is no albuminuria here. Most of the trials, they have included albuminuria. Had they included albuminuria, there would be a different curve. But they did not include the albuminuria. In a way, that's good. But that did not show a statistically significant benefit. So that was a little bit of a disappointment, and I'll answer that. Why? The mean GFR decline, however, was reduced by 32% at 4 years. And if you see, patients who had an eGFR of more than 60 and those who had an eGFR of less than 60, that's technically CKD. Here, it arrested the decline of the eGFR. Now, by SGLT2 inhibitor use, so risk of MACE, whether you are on SGLT2, whether you are not on SGLT2, it doesn't make a difference. Non-fatal MI, whether you are on SGLT2 or not on SGLT2, doesn't make a difference. Non-fatal stroke, similar story, doesn't make a difference. So, this gives us reassurance about two things. Clear, unambiguous reduction in 3-point MACE in a continuous process where the two curves diverge, non-fatal MI, and major adverse limb events. And I think the adverse events, as we know, is due to the GI disorders. The discontinuation was 15% as opposed to 11%. So absolute numbers, if you see, there's a 4% increase in discontinuation in the semaglutide arm. Now these were my questions. Why was stroke not reduced? हम लोग पढ़ के आए हैं कि GLP-1 stroke कम करता है. That was also my viewpoint, but I'll show you this meta-analysis. Now, if you look carefully, this is the non-fatal stroke data of all the GLP-1 receptor agonists. You will find it's only the rewind here. That's the only one which had reduced the non-fatal stroke. None of the GLP-1 receptor agonists actually reduced the non-fatal stroke. it was tendency, but not statistically significant. So that's a wrong opinion. कि ये तो करता ही है. No. So therefore, soul was not an exception. Again, with the soul, it was on the correct side, but not statistically significant. CKD. Now, if you include albuminuria, and if soul had included it, then it would be here, statistically significant. So this is the data if you include albuminuria, and you can see here that many of them are statistically significant. But you take out the albumin component out, only the EGFR, GFR dropped to by more than 50%, dialysis, then everything goes into the midline, except perhaps for the rewind trial. Now, so the question is, why did SOUL over a period of 5 years did not cause reduction statistically significant in CKD? So I asked this to the trialists as well, because we don't know the exact answer to this, but it seems to us that if you have CKD, then it tends to work, as opposed to if you do not have CKD. So as I told you, the mean EGFR was 73, and 70% of patients had EGFR of more than 60. So they were renal healthy patients. We don't have a teased out data between the EGFR of 60 or more than 60 as far as renal outcome. But आपका अगर किडनी में गड़बड़ी है तो काम करेगा, because that means the inflammation has set in. And once inflammation has set in, it will work. If the inflammation has not set in, it's not going to work. So that was the justification. So this is borne out by the fact in the FLOW trial, where the mean EGFR was about 47. And you can see the inclusion criteria itself said that EGFR 50 to 75, but ACR more than 300, or EGFR 25 to 50. So the mean EGFR on the FLOW trial was 47. So they were renally sick patients where inflammation had set in, and here it worked very well. And you can see that there is a 24% reduction in the major kidney disease without albuminuria. Albuminuria को नहीं रखे उसमें. Albuminuria को कम करके क्या फायदा अगर हम लोग क्रिएटिनिन को नहीं बढ़ने से रोक पाए. Now, the other study with the limb events it is tried, and this is the very rare studies with anti-diabetic drugs in patients with peripheral arterial disease. So this is an injectable semaglutide used in patients who have peripheral vascular disease, and you can see here this was the inclusion criteria, and therein it showed that at 52, 57 there was a clear increase, more than 26 meters, so close to 100 feet increase in their walking distance. And that's a big amount for a person. We are not giving any additional antiplatelet agents. Just by this drug, we are able to increase it. So now you have got two different data, one dedicated trial for peripheral vascular disease and one CVOT with a secondary outcome of peripheral vascular disease. Now, question is, what about pancreatitis? What about retinal disorders? So here you see the pancreatitis here, acute pancreatitis, those were similar. If you look at the meta-analysis of GLP-1 receptor agonists and compare it with DPP-4 inhibitors, you will be surprised to note that the DPP-4 inhibitors cause more pancreatitis than GLP-1 receptor agonists. That's based on a meta-analysis, and that's very surprising. I don't know the answer to that. But nevertheless, the pancreatitis rates were similar. Retinal disorders, again, 22.8 and 22.4. Now, this comes with a catch. The patients with proliferative or unstable retinopathy were excluded from this trial. So if you exclude them, then if you do, there is no increase in retinal disorders. So I think in conclusion, you have got a drug now which reduces the MACE by 14%. Moreover, if I tell the patient, आपको 3-point MACE कम हो गया, तो उनको 3-point MACE का मतलब समझ में नहीं आएगा. उनको बोलना है, मैं बोलता हूं कि हार्ट अटैक रिड्यूस करते हैं by 26% और आपका टांग काटने से रोकता है by about 30%. This is what I tell. And the larger effects seem to be there in patients in the Asian origin. And mind you, there were 800 patients from India. So with that, I end. Thank you very much.